Okay, now we're going to get started again for this recording, everybody. And so I apologize for any delay that was there. I had forgotten where we had ended in respiratory. So this is going to be the sort of the combination of lecture and lab. And I saw that we had gone through, uh, in this sequence, PowerPoint A, remember the lungs and all the nuances and the blood vessels that were there. So we had completed that. And this is our starting point. And so the lab is because the lab was going to be pulmonary function studies, we have to address the physiology of the respiratory system. And that's what we're going to do now. And then we'll actually do the lab. I'll set up the technology next time we're in so we can experiment and do the lab. And because that's really the last of the big labs that I think we're going to be doing. And it's kind of up to you, I think. I'll show it to you what we're going to do vis-a-vis the lung, because there's not a lot to see necessarily that's there. So it brings us to so this is sort of what I'm calling a lecture lab hybrid. And these will be my two presentations for the day. I did that relatively brief one to complete the immune system. And now we're picking up with PowerPoint 21B for your reference. And I'll put these videos on week 4, starting with this one. But I'll put the one on the end of the immune system at the bottom of week 3, I believe. So pulmonary ventilation, breathing. So in and out, very simply. Most of this has to do with pressures. I don't do this. This is physics. Suffice it to say, we basically are at sea level. We're a little bit above it, but not a lot. So we call it 1 atmosphere of pressure. Inside of our lungs is effectively a lower pressure. There's a negative pressure based on the anatomy. So it always means that there's a little bit of air going into the lung, and that keeps it even slightly inflated. The biggest problem with lungs that you will see is when too much air goes in, it will collapse. So there's a negative or suction pressure pulling air in to keep the lungs somewhat inflated. The big problem is when when it's uninflated, imagine it's like your hands clapping together and they start to stick. It's like you had something on your hands and you can't pull them apart. And the longer they're stuck there, the more likely it's going to get permanently stuck. And that's exactly what happens with the lung. That's what the surfactant does. The surfactant from the type 2 cells is like a moisturizer or a wetting agent. It's a tiny degree of lubrication that allows them to open and close relatively easily. To avoid additional problems, there's a subtle amount of inflation. So it's effectively a negative respiratory pressure, less than an atmosphere. Okay. And so they go through all the numbers, and I'm going to try and do it. So they look at the different pressures, and yes, it fluctuates with breathing. What happens when when we expand our chest to inhale, even though you don't think of taking a deep breath, you're flattening your diaphragm, you're expanding your chest. That increases the volume of the lungs. Well, pressure and volume have an inverted relationship. If you increase the volume, you decrease the pressure. That's the impetus. That's what allows that air to come in. And we reverse it when we exhale. We relax those muscles. We don't even have to use any extra energy to do that. And then boom, out it comes. But we don't get completely to it. And they go through all the numbers there, but usually it's about 4 millimeters for a sneeze. So apologies for that. I've had these allergies all day. And so it keeps a little bit of fluids, and the lymphatics, they help you with regard to this. So what allows there's a natural, because the lungs are elastic, they try to get smaller. So again, the fluid surface tension is really important. There's a little bit of fluid on the exterior of the lungs. There's the surfactant. There's a little bit of fluid on the interior of the wall of the pleural cavity. And those fluids and there's a certain amount of surface tension. It's like it's fluid, it's adhering to fluid, sort of like water likes water. It's one of those interesting properties of water. And so what happens, it's almost like you put your finger on in a pool, and you can start to pull it away and the water pools with you. But that, to some extent, that also helps to expand the lungs and keep them expanded. So a lot of these things are part of it. So even though the elasticity is trying to collapse it, the adherence of that little bit of fluid between the parietal pleura, the lining, and the lining on the exterior of the lungs really makes a big difference. And they go through all these different pressures, and I'm not going to go through it. And they're trying to show you, but eventually we get to the difference. It's about 4 millimeters of mercury. Not a lot, but it's enough to keep the lungs at least partially inflated. What happens? You're driving, and before we had airbags, people would get hit by the steering wheel, and it would cause damage to that parietal pleura, and eventually a fractured rib would allow for a lung to collapse. Certainly, we see when somebody's bronchioles are plugged with pneumonia or other kinds of diseases, but traumatically, what happens is they get something called a pneumothorax or tension. Tension just means pressure. Pneumothorax. And what happens is a wound or some type of internal damage, a tumor, or those types of things. We have to. What happens is effectively air rushes into this cavity, which normally is at negative pressure. When the air rushes in, it overwhelms and adds to that elastic property of the lungs, and they collapse. And if you don't reinflate them, there's trouble. So it's a big deal to reinflate a lung. It's really something that's done in emergency rooms with some degree of frequency. You have to pass something called a chest tube. It's a tiny tube that goes in and sucks the air out. You put it on a suction or suction into the wall and adjust it. And the lung will then reinflate. And you do that, and slowly you'll be able to, as the pleura heals, the lining heals completely, you'll be able to remove the tube and the person will survive. So typically it's just one. Sometimes it can be both in a really severe accident. That person's really in jeopardy. They can breathe with the one lung for a while, but if you don't reinflate it, then they're really prone to pneumonia. And it's just volume. And this is because there's a constant relationship in chemistry. And maybe you've heard of it. It's called the ideal gas law. It means pressure and volume maintain a constant relationship. So V and P always have a constant value. If pressure goes up, volume goes down. If volume goes up, like when you're inhaling, pressure goes down. And so, and all of these laws, and these are names that you might have to remember: Boyle's law, okay, relationship between pressure and volume. And when they say about inversely, so all that means is pressure goes up, volume goes down, and volume goes up, pressure goes down. And they're always whenever those numbers are always going to be equal. And so we take everything, really, that's the ideal gas law being extracted or manipulated mathematically for these laws that we talk about so much in respiratory physiology. So the only time you're expending energy normally, unless you're taking a deep breath or blowing out the candles, is during inspiration. That's active, means you're expanding energy. The diaphragm flattens. You use your external intercostals, and they lift and sort of lift it up and out the rib cage, okay? And that increases the volume, lowers the pressure, air comes in. And they're just showing you just showing you from here to here. Lungs are stretched, the pressure drops by a millimeter of mercury. Not a lot, but that's enough to bring an increased amount of air in. And that's what they're trying to say. Now, if you're trying to take a deep breath, you're going to use more energy. Okay. And so we do that when we're exercising, and particularly when we get toward the end of the chapter, not today, we'll talk about these problems like emphysema and chronic obstructive pulmonary disease, abbreviated COPD. Okay. A lot of times, and what makes it really fatigues people with breathing problems like this is breathing is effortless for you and I, thankfully. What happens with folks like that who have to be on oxygen all the time, they have to use all these other muscles that to assist them in doing this process, back muscles. So they're extraordinarily tired. Okay. And what happens is that plays a role. By using those muscles, they tend to alter the shape of the cage. And so if anything, so what they're trying to do is increase the size of the thoracic cage, but it becomes increasingly more difficult over time, as well as being very fatiguing. So it's really annoying. The only other time that you again use extra energy, because exhaling, you're just relaxing. And the elasticity and the muscles going back to their normal position will facilitate the exhale, because the volume will decrease and the pressure will increase, and it'll push the air out. So unless you're forcibly exhaling, blowing out the candles, straining to do something, that's about it. So quiet expiration is normally passive, and it just reverses the process. Forced, okay, when you start to use your abdominal muscles and the internal intercostal muscles, more energy. And like that, and they go through all these slides. It's not necessary for us. And so we look at this. This is a way of measuring in and out what's going on. And so, very famously, this has got an important name. It's the amount of volume that you and I go from at rest, inhale, and then we exhale. It's roughly for both of us, without you even noticing it, about 500 milliliters, a half a liter. So we're moving about 2 pints, if you want to think of it in our measurements of gallons and quarts and pints. I beg your pardon. We're moving about 2 quarts rather of air in or out with typical breathing. It may not seem that way, but it does. That's called the tidal, TIDAL volume. Okay, and there's other things that move air in and out. We call them because you're not breathing per se. Okay, and they modify it. So, I mean, you cough, you sneeze, you cry, you laugh, you hiccup, you yawn. So those are really not assisting your breathing, but they're things that also move in and air out. Not a big deal for you to remember them. And what are the factors that impact this? Resistance, surface tension, and compliance. Resistance. Okay. The surface tension, you're going to see a surfactant. The compliance is the inherent stretchiness or elasticity of the lung itself. And that's something, unfortunately, that decreases with age. Those elastic fibers, I hate to say they have a lifespan, but they're just not as stretchy. It's the same reason you want to think what compliance is. If you're having a party, you're going to blow up a balloon and you don't have the helium tank, you're just going to blow it with air from your mouth. What do you do first? You stretch the balloon a little bit. It makes it a little inherently, it makes it more stretchy, if you want to consider it this way. And resistance means, are there any obstructions in the way? So major non-elastic torsion resistance occurs in the airways. That's where it is. Are they stretchy enough? So is there any type of damage? Is it an older person? And you go through all the physics behind it. First of all, in the early part, the openings are so large, we don't have a lot of resistance. But when we get, just like in arterioles, where do we control blood pressure? Down in the arterioles, where there's, it's, even though they're extraordinarily small, there's so many of them. When you add them all together, you have a lot of surface area. So it's about total cross-sectional area. And so where we see the resistance is usually as the bronchi start to get smaller. And it disappears as they get particularly smaller, because that's when diffusion, once it's close enough to the alveoli, then the oxygen and carbon dioxide will just move on their own. So again, your big area where we see an increase in resistance in those medium sized. Remember, we started with primary, secondary, tertiary. We start to get smaller, let's say, than these tertiary or segmental bronchi, and they start to get smaller. That's when it begins to get increase of resistance. And unfortunately, when you have a cold, flu, COVID, those are the areas that are most impacted. And then you can see what happens. It just drops precipitously once you get past that sort of a blockage area. What are you doing, Pooch? He's chewing something he shouldn't. So, more strenuous, severe constriction or obstruction, until all of those things. So, an asthma attack, you're in those small areas. You can't punch a hole in somebody's throat because that's not where the problem is. You can't breathe, so you can't breathe for them. And again, epinephrine would be one of those things that will play a role. Surface tension. So that's that interface where liquid molecules. I have to get up and take something away from the dog. You're into mischief, young dog. Hold on, everybody. I'm coming. Hold on. Give him a biscuit. We're exchanging. Take this. Bark for everybody if you feel like it. They'll know you're here. Back we go. So the surface tension, liquid molecules come close together. Okay. So because of the surface tension, conceivably it could be a problem. So the surfactant, it's like a detergent. It's like, why do detergents work? Because they basically ease up that surface tension. They release it. So it prevents the alveoli from collapsing. So it's like when you exhale, again, normally those lining cells might adhere to one another, but the surfactant, and that's why there's so many problems with premature babies when they, particularly pre 26 weeks, because they couldn't make surfactant. Now that we make surfactant, preemies can survive longer, even though it's extraordinarily tiny. So this is where they talk about infant respiratory distress syndrome. Interestingly, when you're hearing a lot today about RSV, respiratory syncytial virus, it's very frequently associated with this. That's there. Even though it's typically more common and more dangerous in very tiny ones, now we're even seeing adults. Like my wife had a horrible case of it in September. So the increased surface tension, they continually collapse the amount of energy, premature babies, again, until they have to have at least 2 months of development before you get to. So when we're starting to get into that, so if you figure 2 months is at least, fetal ones do not produce adequate amounts until the last 2 months of development. So you take it away from 40, now you're getting down to about 30. And so anything prior to that, there's, depending on the health of the infant, at least we started to get some production maybe around 26. That gray zone was 24 to 26 weeks. Prior to 24, don't even go there, young man. The dog. Okay. So natural or synthetic surfactant into the pet because we now can make it. Okay. And sometimes in severe cases, we have to assist. And the compliance, the stretchiness. Okay. Normally it's very good. Okay. The more compliance means it's more stretchy, easier to expand. And they give you a whole thing like that. But it can diminish. It diminishes with time. It diminishes with infections, tuberculosis, surgical intervention, all of those things. And unfortunately, as people get older, as well as the cartilages, which you probably talked about a little bit in AP1, those costal cartilages between the sternum and the ribs, they start to become bony, paralysis, things like this. And then the last section I'm going to do, because I have a dog who's upsetting, is we're going to do these pulmonary function studies. That's the next part here. And that's the last part I have to do for today. Thank you. And he is ending the lecture because you're probably hungry.